So the management of fractures, the acute management of fractures, meaning what you need to do there and there before anything else, before you say you're going to refer the patient, you need to splint that patient. So you must put a back slab for that patient. Back slab, it helps in so many different ways. It helps with the pain. It helps with the swelling. It minimizes the chances of a fracture displacing and complicating the fracture. It minimizes the chances of, because obviously if you displace the fracture or even worsening the fracture, because if you are gonna not stabilize that fracture, you run a risk of a neurovascular injury. So it's very important. It also helps with pain by putting a back slab. All fresh fractures should have a back slab put on them and not a full POP, not a full plaster of Paris. Because if a fracture is fresh, it has occurred within the last 4 hours. Some books say 6 hours. But personally, what I do, as long as the fracture, as long as 24 hours has not elapsed since the fracture, I don't put a full POP on that patient. I put a back slab. Because the reason why you put a back slab is because you want that patient to go home and allow the swelling to take place up until the swelling reduces again. Because if you put a full POP and you send the patient home to come back in 4 weeks or whatever, or in 2 weeks, without having allowed the swelling to go up and then go down again, you run a risk of causing compartment syndrome. Because if the muscles are swollen and also you have tightened the cast around them, there's no other place they can go to. They will swell within that cast so much that blood supply is compromised, their nerves are compromised. The patient then comes back with a dead limb. So that's why it's very important. It's very important to put a back slab. At least a back slab, you've got that part where you've got a crepe bandage around. That part will help when the patient is swelling up, when the swelling continues, and then they will have, the muscles will have at least a room to continue with the swelling up until then it reduces again. And that's number one. Number two, if that doesn't happen, if you put a, let's say that doesn't happen, but if you put a full cast on a patient that is still swollen, when that swelling goes down, that cast will become loose and it will not stabilize the fracture. So those are the 2 points that I wanted to explain. Another thing is the issue of pain management in fractures. There's a lot that people say out there, but what I've decided to stick on is that I don't give my patients NSAIDs. I give them an opioid and paracetamol. Most of the times it's tramadol that I give them. I don't use NSAIDs. I don't use diclofenac. I don't use Brufen. I don't use Disprin. I don't use endomethacin. So the reason for that is those drugs have been proven that they delay healing. They can even cause malunion. Remember, when the fracture is still fresh, within the first 48 hours, there's going to be an inflammatory response that's going to happen to help the healing. So once because an anti-inflammatory is going to sort of like delay or halt or stop that inflammatory response, that inflammatory cascade that you want. So when you do that, you are going to cause delay and or even malunion. So I don't use NSAIDs on my patients. What else did I want to say? Okay, another thing with fractures, never remove a cast from a patient and never send them to physio, because especially if the joint was involved. Especially if the joint was involved. If it was a mid shaft, but even with a mid shaft, you still, if you've got a mid shaft fracture, you're still gonna put a POP on that patient, and there's gonna be a joint that will be covered, that POP. Because you will never have a mid shaft fracture and then you just have a POP that is sort of like applied midway. You are gonna involve a joint. So that joint now for that 6 weeks or 8 weeks is not moving, it's just sitting there. So you need a physio to help that joint to say, okay, let's remind you how to walk and all that and all that and all that. Then so by doing that, you are just minimizing chances of stiffness, contracture flexures, all those kind of things. So physios are very, very important in fractures. Not only in fractures, in so many things. We need to maximize physiotherapy. What else am I forgetting about fractures? I think that's about it, guys. I think that's about it. Thank you so much. Thank you, thank you, thank you, thank you.